Good morning. Welcome to this morning's residential lecture. Today, Ms. Carvalho-Fischer will be talking about an endocrine topic. She's a first-year resident, and she will be talking about parathyroid glands. Enjoy.
So good morning. As was already said, the subject of today's talk is hyperparathyroidism and the role of surgery. We'll begin with some background information. We have 4 parathyroid glands, 2 up top, 2 at the bottom. They're generally on the dorsal aspect of the thyroid gland. However, their location can be very variable due to embryological migration patterns. So it's important to know where this structure is, the recurrent laryngeal nerve, because the superior parathyroid glands are always dorsal of the recurrent laryngeal nerve. The inferior parathyroid glands are always ventral of the recurrent laryngeal nerve. Let's start with the physiology. When we have low plasma calcium levels, the parathyroid glands produce parathyroid hormone. Parathyroid hormone leads to the extracellular matrix of cortical bone to be broken down, and calcium and phosphate are released into the plasma. Parathyroid hormone also increases calcium reabsorption in exchange for phosphate and leads to the activation of vitamin D, which in turn increases calcium absorption in the small intestine. So when all of this happens, our calcium levels rise, and over a negative feedback loop, our parathyroid glands are told not to produce as much parathyroid hormone. So now to the pathophysiology. During this talk, we're going to be focusing on primary hyperparathyroidism, as this is principally a surgical condition. During primary hyperparathyroidism, there's a continuous elevation of PTH because the parathyroid glands produce too much hormone or too much hormone in excess, irrespective of the feedback loop. So what happens is that the extracellular matrix is broken down, as we said, a lot of calcium is reabsorbed, phosphate is excreted, and we get hypercalcemia. Hypercalcemia leads to hypercalciuria. And due to the exchange of calcium and phosphate in the kidney, patients will present with hypophosphatemia. The negative feedback loop we talked about earlier is interrupted. For background information, secondary hyperparathyroidism, here the problem isn't in our parathyroid glands, but rather either in the kidney, so through chronic kidney failure, or due to a long-term vitamin D deficiency. We get low levels of calcium, which then lead to excessive production of PTH. So patients here will present with hypocalcemia rather than hypercalcemia. And then we still have tertiary hyperparathyroidism, which develops on the basis of secondary hyperparathyroidism. So due to long-term low calcium levels in secondary hyperparathyroidism, the parathyroid glands are stimulated so heavily that they develop their own autonomy and begin to produce hormone in excess, causing hypercalcemia. So back to primary parahyperthyroidism, maybe my colleagues can help me out. What are the most common reasons for presentation? What are the most common symptoms?
Bone and joint pain.
Recurring kidney stones and fractures.
Polyuria and abdominal pain.
Fantastic. So a good way to remember this is stones, bones, abdominal groans, and psychic moans. Kidney stones are a big problem. Polyuria is mentioned. Also, nephrocalcinosis can rarely occur. Bone and joint pain can occur. Incidental fractures can occur. Patients often complain of nausea, vomiting, abdominal pain. Peptic ulcers are more common in these patients. And there are also a number of neuropsychiatric symptoms such as fatigue, depression, or even myopathy. These patients also tend to have a higher cardiovascular risk and suffer more from hypertension and bradycardia. What's important to remember, though, is that half of our patients are asymptomatic at diagnosis. Okay, so at this point, I'd like to present a case of a 25-year-old woman with recurrent kidney stones. She did not have bone or joint pain, did not suffer from fractures of any kind. She didn't have abdominal pain. She did suffer from fatigue. And when she first presented, these were her lab values. She had increased calcium, hypercalcemia, hypophosphatemia, and hypercalciuria. So these three should sound relatively familiar by now. Our patient also had elevated parathyroid hormone levels of 141 nanograms per liter, the normal range being 15 to 65. So what causes primary hyperparathyroidism? What's the culprit here? Adenomas are usually the cause of hyperparathyroidism. In most cases, only one parathyroid gland is affected. However, sometimes disease can be multiglandular. Carcinomas of the parathyroid glands are very rare, though they can also cause primary hyperparathyroidism. At this point, it's important to remember that there are familial causes for adenomas, such as multiple endocrine neoplasia, type 1 mostly, but also type 2A, familial isolated hyperparathyroidism, and hyperparathyroid jaw tumor. So where do we go from here? What is the treatment of hyperparathyroidism? Do we perform surgery on all of our patients with primary hyperthyroidism? What are the indications for surgery? Again, a question to the residents.
Symptomatic disease.
Very good. What else?
Young patients and osteoporosis.
So the important point here is that symptomatic primary hyperparathyroidism is an indication for surgery. So our kidney stones, our bone and joint pain, and our abdominal pain. However, asymptomatic primary hyperparathyroidism is a little bit more complex. So young patients, as previously mentioned, patients with elevated calcium or significantly elevated calcium, patients who have imaging that is positive for osteoporosis or osteopenia, patients with low energy fractures, or patients with any form of renal involvement, so a reduced GFR, nephrocalcinosis, or high stone risk. All of these patients qualify for surgery. So once we have decided that our patient is a candidate for surgical treatment, we can perform localization studies. An ultrasound tells us something about the shape and the structure of the parathyroid and thyroid glands. So it's a morphological study. Nuclear imaging with sestamibi tells us something about the function of the parathyroid glands. And thus, combining morphological and functional studies increases sensitivity of our localization studies. Once we have done that, we can think about our surgical approach. So if we suspect a single parathyroid adenoma, a focused exploration would be our first option. This can be done through an endoscopic approach or through a limited incision, also called OMIT. We'll come back to that later. If we suspect multiglandular disease or we have imaging that is either negative or discordant, we can opt for a normal length incision and a bilateral exploration. So bilateral exploration has a very high success rate and a low morbidity. Through intraoperative PTH analysis and through improved localization studies, the minimally invasive focused approach is equally successful to the bilateral exploration. As seen here in this study, both approaches were compared. After 1 and 5 years, there was no difference in the levels of serum ionized calcium and serum PTH. So how does this intraoperative PTH measurement work? We measure PTH before resection, then we resect the parathyroid gland, and then we measure 10 minutes after resection. We use the Vienna criteria because they have high sensitivity and specificity. The Vienna criteria are when more than 50% decrease of intraoperative PTH 10 minutes after excision of the parathyroid glands is observed, then we can terminate the surgery. So back to our case, our 25-year-old female, I think we can all agree that she's a candidate for surgery. So ultrasonography and sestamibi nuclear imaging were performed elsewhere, not at this hospital. We do, however, have a choline PET CT. The choline PET CT is a combination of functional and anatomical imaging, and we can see here, this is our hyperactive parathyroid gland right there. And this is the parathyroid gland that was removed during surgery, this brown bean-like structure, is the adenoma. So open minimally invasive parathyroidectomy is the most common procedure. In these cases, we make a limited incision above the suspected parathyroid gland. We visualize the parathyroid gland and the adenoma. The adenoma is mobilized, and the parathyroid gland is separated from its vascular structures. And preoperative PTH in this case was 255 nanograms per liter, and 10 minutes after resection of the parathyroid glands, it was at 31.5 nanograms per liter. It's important to remember that the PTH is only in the blood for a short time, which is why this analysis is possible. Okay, so why do we even perform surgery? Symptomatic patients will hopefully become asymptomatic, and even for asymptomatic patients, surgery has benefits. So this hospital register-based Danish study compared about 700 patients with primary hyperparathyroidism to 2,000 normal controls, so population-based age and sex-matched controls. And they were able to show that 10 years after surgery, the risk of kidney stone formation is equal in both groups. A post-operative increase in bone density can also be observed. So and this is a long-term effect. This is especially true for cortical bones such as the radius. So what are the pitfalls of this procedure? What can happen? Maybe this is a question again for my colleagues.
Recurrent disease.
So the disease can recur.
Bleeding, hypocalcemia.
You can have infections and also a cervical hematoma.
Fantastic. So as in every procedure, bleeding may be a problem. It's important to mention cervical hematoma at this stage. We'll come back to this at a later point. Infections are rare, but also possible. Injury to the recurrent laryngeal nerve is a complication to bear in mind. Equally, disease can persist in 5% of cases and recur in 8% of cases. So cervical hematoma. It's important to remember that an expanding hematoma can cause airway obstruction and asphyxiation. Symptoms are neck swelling, pain, airway obstruction. What do we do in these cases? We open the surgical incision bedside as soon as possible and transfer the patient to the OR. How is this prevented? Through careful intraoperative hemostasis. Post-operative hypocalcemia is more common in cases of parathyroidectomy after secondary or tertiary hyperparathyroidism. Patients are mostly asymptomatic after surgery, even if they have hypocalcemia, but symptoms can be circumoral paresthesia, acroparesthesia, tetany, seizures, laryngospasm, or QTC prolongation. The therapy of postoperative hypocalcemia is substitution of calcium. Depending on the severity of it, we opt for either oral or intravenous calcium. So, to the pros and cons of surgery, patients will have less kidney stones after surgery. Their bone density will increase. Although it's harder to measure, some studies indicate that neurological psychological symptoms decrease, that quality of life increases, and our cardiovascular risk factors decrease equally. On the other side, the cons of surgery are possible complications, such as hemorrhage or damage to the recurrent laryngeal nerve, persistency of primary hyperparathyroidism, or recurrence of primary hyperparathyroidism. If our patients do not qualify for surgery, it's important to schedule regular follow-up. So calcium should be measured yearly, as should creatinine. Bone density measurements should happen yearly or biannually. Medical treatment can include anti-resorptive drugs or calcimimetics. Patients should avoid thiazide diuretics, dehydration, vitamin D deficiency, or sex hormone deficiency. What are our take-home messages for today? 50% of our patients are asymptomatic. The symptoms can be remembered with our great little sentence here: stones, bones, abdominal groans, and psychic moans. symptomatic primary hyperparathyroidism requires surgery, and patients with asymptomatic primary hyperparathyroidism also profit from surgery. Surgery reduces the risk of kidney stones and improves bone density. And that was it. Thank you for your attention.
Thank you very much. Very excellent presentation. I mean, for us, it's always good to review all these things regularly because sometimes we forget a few things. So thank you very much. It was very didactic. How many of these operations are done in Switzerland? Do we know about a year?
No, actually in September we have a meeting and then the numbers will be shown from the centers that are included in the international database, so we should know by then.
So now we have an international database where we can monitor, the numbers, but also complications. And,
yes, everything is in there. Yeah.
So it come again with all this topic of centralization, etc. Although I mean, it was typically an operation performed by general surgeons, thyroid, parathyroid, etc. And it's pretty clear from data that if you do one every 4 years, probably not the same that if you do it regularly. Would you comment into this? I will not go the debate or discussion who should do it, general surgeon versus ENT people. But I mean, in terms of number, experience, from the patient perspective, where should we go?
For sure, it's true for this disease as well as for other diseases. The parathyroid glands especially, Cynthia nicely showed that the localization can be quite difficult at very different positions. If you have a nice localization like we had here with the choline pit, that's pretty simple. It was 2.5 centimeters below the lower pole of the thyroid. Then many people can find it, but it's not often that obvious, so it needs a lot of expertise. And also, there are a lot of structures that are sensitive and that you can, with experience, you can help. There's also data showing the complications are reduced by experience. Not to zero, but that's the specific thing with the recurrent laryngeal nerve. Will never, well, maybe not never, but currently even the ones with most experience will have 1% of persistent laryngeal nerve.
You test during surgery?
We test the nerve damage, yes.
And how that decrease? What's the impact of decreasing injury? If you test after the injury is done, it doesn't matter much.
Exactly. So the data that is there so far doesn't show that the monitoring really decreases the risk. There's data coming now that there's real-time monitoring of the nerve that might even decrease the risk of the injury because you see when there's tension on the nerve. But so far there's no data that shows that there is a decrease. But what it does do, it actually changes your approach. If you have a bilateral disease and you have an injury to the laryngeal nerve on one side, you will not go to the other side. You will wait because most of them do recover, and then you go to the second side and the second step. So it's more for the safety of the patient.
Thank you very much. Excellent talk. What is your strategy if the preoperative imaging doesn't show a clear localization and you have a patient with a primary hyperparathyroidism? What is your strategy intraoperatively, or what would you do?
The things that Cynthia showed, there's a sonography and the scintigraphy. That's the gold standard of localization diagnostics. If that is negative or not or discordant, what we do here, and that's we do the choline PET, which has a higher sensitivity. We have less false negative, because the problem is for the sonography you have, if there's nodules or if it's behind the bones, then you might not be able to localize it with the ultrasound. And for the scintigraphy, it's a problem if the adenoma is not very big. You need an amount of mitochondria, you need an amount of cells for the scintigraphy to be positive. And if it's a rather small adenoma, doesn't mean that doesn't make a problem, but if it's a small adenoma, you might miss it in scintigraphy. And there the sensitivity is higher in the choline PET. If you still have a negative and you really have an indication for surgery, someone who has really high hypercalcemia and who have an issue, then it's still the bilateral exploration of all 4 glands that you do, and then you go for the one that has the aspect of being enlarged, and then you take it out and you use the intraoperative PTH measurement for functional control, then you know if you're right. Yeah.
So you go gland by gland and take it out and measure?
No. I mean, you do an exploration of all 4 glands. I mean, if you find one that is obviously enlarged, then you take that out. It's and you do the intraoperative PTH measurement. But I have to say that is quite rare.
Excellent presentation. The problem with the operation is that sometimes the adenoma is very hard to find, isn't it? And there are new technical gadgets on the market to visualize, because those adenomas have autofluorescence. And it might be interesting to have some insights on this, because we had this already here, and it's quite a new development, isn't it?
It's true. That's something we're looking into now. It's really a very interesting topic because, as you said, the parathyroid glands autofluoresce, and there's devices on the market that can be used to localize the parathyroid glands. And they can not only localize the parathyroid glands, they can also be combined with ICG green so that you can actually see the vessels and avoid cutting the vessels. But this is more for thyroid surgery, right? If you're doing an adenoma and taking an adenoma out, you might not want to. It's not so important where the vessel is. Yeah, absolutely. It's a good device, and we're aiming at getting it.
If you have an adenoma and you take it out, how often it happens that the patient is going to be hypoglycemic because the others don't take over? Kind of they were suppressed for a long time. And
so for primary hyperparathyroidism, you will see it in the labs. Often you will see that the calcium goes below normal, but they won't be symptomatic. It will just below the normal range. They won't be symptomatic, but we give them calcium because this is just the bone takes the calcium. But the parathyroid glands, they actually take up quite quickly. I haven't seen that they don't take.
Suppressed for many years.
If you have 3 parathyroid glands, you won't have a long-term hypocalcemia. But we give calcium after the surgery so that the bone has something to build up on. It's different for secondary because they have, and tertiary also because, of course, they have more stimulation of all glands, and they have more severe hypocalcemia afterwards when you do the surgery. And also the surgery is a different one. That's not the topic of today, but if you take out more glands and only have a minimal part left, of course, you might have a hypocalcemia afterwards. But if they're just suppressed, they'll start working again. Okay, thank you.